Hey, good day and good evening, everyone. It's Tuesday and next webinar to come. Please let me know in the chat section if you can all hear me and if everything is working fine. And thank you for the feedback. I'm glad to hear that everything is working. I'm Sophie and I'm your host today. And welcome to IVF webinars by Egg Donation Friends. Hi to everybody who is joining us weekly. And of course, huge welcome to those of you who are with us for the first time. We're here to help you along your IVF journey and to put all the pieces together and to dispel all your doubts. And each and every IVF webinar is recorded and the rewatch is available on our website next day after the live event. So tomorrow you will find the rewatch from today. And you can all find it at eggdonationfriends.com/IVF-webinars. IVF webinars are brought to you with help of our partners, and our partners are National Fertility Society, Fertility Clinics Abroad, and Donor Conception Network. And today, we are here to talk about IVF with donor eggs and about guarantees and about oocytes and embryos and pregnancy and live births guarantees. And of course, we are here today with Dr. Tomas Frgala from UNICA Clinic in Brno. And Dr. Tomas is a specialist in the field of reproductive medicine with over 20 years of experience. During his work at the University of Southern California, he participated in numerous projects and studies focusing on research on new substances in tumorous disease treatment. And recently, he has engaged himself in the research on new methods in the field of assisted reproduction. And Dr. Tomas is head physician at UNICA Brno Clinic. The presentation will take around 20-25 minutes, and just right after the presentation, we will follow with the Q&A session. So if you have any questions coming up now or later, just feel free to type those questions in the chat section. That's all from me for now. Dr. Tomas, if you are ready, we can start.
Yes, hello.
Yes, hello. Good luck, fingers crossed, and let's
you.
do IVF webinars today.
Hello. Hi, ladies and gentlemen. Thank you for taking your time and spending it with us, discussing this topic, the IVF with donor eggs and the guarantees explained, a rather ambitious title, maybe more humbly an attempt to explain some of the guarantees available. I'm going to venture a guess that some of you, perhaps many of you who are listening in today, have already been through an IVF cycle with stimulation of your own eggs and fertilization. Stimulation of your own ovaries to get your own eggs, of course, and the fertilization of these eggs. And unfortunately, some of you may know that it is not always that the IVF ends with a positive outcome, that many factors actually influence the outcome of the procedure. And of course, even though after every cycle we try to analyze the cycle, we try to fill in the blanks, so to speak, and examine everything that might actually help us recognize why the cycle was not successful and what can we do to increase the chances for the next one. Still, there are cases where after 3 or more IVF attempts with repeated implantation failure or repeated miscarriages, there might be time to consider alternative solutions. When we look for possible causes of the repeated implantation failure or the lack of success generally, then we always look at the basic building stones at first, okay, and that's the sex cells, the gametes, the sperm cell, the egg. Even though it's usually quite difficult to distinguish and to draw the line, to even venture a guess, whether it was more the question of the sperm cell quality of the egg quality. Still, all in all, most of the data published actually says, or points towards the quality of the resulting embryo as the major factor in the success of the IVF cycle, and supposedly the embryo carries up to 80% of the responsibility, and only the remaining 20% are actually a question of the uterus, the endometrial receptivity, and other factors such as the hematology, immunology, and other aspects. So, if we want to consider a cycle with egg donation, if the situation is such that after previous attempts without any success, or in a situation where the indication is actually quite obvious, now when does that happen, and what do we need to count on? Well, the treatment with donated oocytes is recommended when the woman does not produce her own eggs, or if the eggs are of poor quality. Generally, these are situations where either the patient does not have ovaries anymore, perhaps following a surgery, or if she suffers from premature ovarian insufficiency, a situation where quite often a young, very young woman, well under 40 years of age, actually cannot produce follicles bringing mature eggs anymore in the cycles. It's also the situations where there's a poor oocyte quality in the previous IVF cycles, with recurringly a low number of collected eggs, or a failure of fertilization, poor cleavage, meaning poor embryo development during the in vitro stage, poor implantation, or repeated miscarriages, as we have already mentioned. There are also cases where there's a clear genetic indication or recommendation, where on one hand the woman might have a sufficient ovarian reserve and maybe even a good egg quality generally, but there is a problem in the karyotype, deletion, a translocation, or maybe some other specific mutation that actually might lead to conception of embryos that won't be healthy, that won't be able to implant, or maybe will be able to implant but will be miscarried, or worst case scenario might lead to actually birth of a sick baby, of an unhealthy child. So sometimes it is directly from the geneticist that it's recommended to use donated eggs. Of course, endometriosis can lead to some of these situations, such as the ovarian insufficiency or the surgeries. And there's one factor that actually is very important, and that's the age of the woman, of the patient, the age promising good quality eggs from her own ovarian reserve. The line between these two situations, between a patient with ovarian function without it, is actually quite blurry. And as you may know, and as kind of already was touched in the previous slide, it can be, for instance, endometriosis that leads to a lower ovarian response, eventually leading to surgical operations, and eventually to a premature ovarian insufficiency. However, the age is actually a factor that goes through all of these like a red line, and it's usually one of our first questions always when we encounter the patient and consider the following steps, and that's the age. Well, the habits in the society may change. For instance, in the Czech Republic, around 2001, the average age of the primipara, of the woman being pregnant and giving birth for the first time, may have been 27 years of age. In 2017, it was already well over 30, approximately 31. And actually, the age of the patients, or of the patient actually seeking help at the assisted reproduction clinic, usually is around 36 or 37. So we choose to get pregnant later, but the evolution doesn't quite hold a step here. And it's still true that the woman gets born with all the eggs, with a whole ovarian reserve that she will eventually draw from during her reproductive age, and that the quality of those eggs is best between, let's say, 19 and 29 years of age, or up to 30 to make it simpler. Then it's still very good until 35. Then the quality of the eggs starts to drop, unfortunately. And around 40, it's usually quite complicated to get pregnant from own eggs, because the egg quality, as they grow older with the woman, it just drops. And it's around 42 actually, when the number of follicles dropping with the increasing percentage of aneuploid eggs, meaning eggs of poor quality, they intersect, and when it starts to get really complicated to get pregnant with own eggs. Well, if that's the situation that pushes us towards that ultimate refuge, the cycle with egg donation with donated eggs, which I believe personally is the best alternative in many of these cases that we have discussed, then we need to ask the questions, well, what are the basic rules in the country where we consider care, because these might differ from country to country, and who are the donors. Um, in the Czech Republic, these are usually young women who decide to volunteer and help others. It's usually female students, university students, or young mothers on maternity leave. The whole procedure in the Czech Republic is by law still strictly anonymous. So it remains the decision of the couple whom, when, and whether at all you might want to inform the baby, the child, or somebody else that the child is from donated cells. You're not forced to do that at all. But on the other hand, if you do decide to inform the child, we're still not allowed to share the identity of the donor. So that's something to eventually consider. These are quite complex psychological questions that we may want to perhaps discuss in more detail during a possible consult, but that's how the rules are set at the time. I was quite intrigued actually by the result of this study from the European Society for Human Reproduction and Embryology, issued in 2017, that showed that actually 50% of the donors gave as the sole and only reason the pure altruism, just to wish, the need to help somebody. Then others admitted that it was for actually the altruism and financial reasons, some purely financial reasons, and others. But I was pleasantly surprised by actually this rather high fraction of young women that were willing just to help somebody without trying to actually gain much by that. The selection process is usually quite similar in the various countries. The same in the Czech Republic. It's quite rigorous, actually based on the international guidelines. The donors, and again, we're not going to go into details, must be of good physical, gynecological, mental health. A rigorous genetic screening is performed, including a consult with a geneticist. They are tested for karyotype, cystic fibrosis, and actually even some special screening methods, like possible mutations for muscular atrophy and connexin 26. So hereditary deafness, thanks to the vigorous Czech Society for Genetics and Genomics, which actually included these in the guidelines starting January 2019. Only when all of these results come back and are negative, everything is in perfect shape, then the candidate is included as a possible donor in the database. In the matching process, We observe the phenotype, eye color, hair color, weight, height, of course, the blood type, and the menstrual cycle, which is important for us because as long as we want to use fresh eggs and fresh embryos transferred and implanted into a fresh endometrium, we need to synchronize these both women, the patient and the donor. And we can do that by a couple of days using pills, for instance. We cannot do it by a couple of weeks. Uh, Okay, some data can be revealed when we actually make that match, and when the person responsible offers or suggests the donor candidate for the couple, such as the donor's age, blood type, height, weight, eye color, hair color, her profession, study design, eventually personal interests, hobbies, and based on the wishes of the couple. But again, most of this is then discussed during the consult. The whole process may look rather complex or complicated in a picture or graph like this, but actually for the patient, it's quite simple. The donor goes through the multiple checkups, including ultrasounds, applies the injections on a daily basis, and then eventually goes through the egg retrieval in complete anesthesia. For the patient, it's usually just one visit at the clinic, and that's the embryo transfer. Of course, there's an ultrasound check earlier, usually performed at the place where the patient lives, so she doesn't have to travel all the way to the Czech Republic for that. And the same goes for the pregnancy test and the ultrasound later. But these two appointments are crucial. The actually fertilization, so the day of the egg retrieval from the donor, and on the same day we need the gentleman or his sperm cells if the sample has been cryopreserved earlier here at the clinic, maybe during the consult, and 5 days later the embryo transfer is performed. So that's where we need the patient here. Either it's two separate trips or like a short 1 week vacation in the heart of Europe. Um, I'm not going to go into detail of the preparation of the endometrium. This is basically just to answer the usual question, what medications does the patient need to take? And the answer is basically just estrogens and progesterone or gestogens. The hormones actually crucial for the menstrual cycle. Estrogens in the first phase, the first initial 2 weeks or so, to build up the endometrium, the uterine lining, and then progesterone to start the secretory phase and make the endometrium receptive, ready for implantation of the embryo. We check the progression, the involvement in the uterine cavity with an ultrasound, usually around day 10, 11, or 12 of the estrogen application. This is the visit I have mentioned earlier that it's usually performed at the place where the patient lives, at her gynecologist. We focus on the quality or the structure of the endometrium, optimally a trilaminar or triple line structure, and of course the height of the endometrium, its thickness. Anything between 7 and 12 millimeters is usually regarded sufficient, although 8 to 10 might be perfect. We all know about pregnancies in an endometrium that was only 6 or maybe even 5.5 millimeters high, but it's actually quite favorable to get it over 7 millimeters, and the success rates increase significantly. If the endometrium is not of the optimal height, we adjust the dose of estrogens in time to get actually before the transfer or before even the secretory rebuild, before that phase is started, to get it to the sufficient height. But earlier, we have mentioned that the most responsibility is carried by the embryo itself. So, how do we check on the embryos? How do we cultivate it? How do we evaluate them? Wow, this might be a topic in itself, and maybe we'll get into the details some other time. This is basically just to show you that there are several options when to transfer the embryo. Sometimes it's on day 3, usually is on it's on day 5. Why is that? Because all the way up to day 3, at least that's what the embryological hypotheses say, it's usually the quality of the egg that is crucial, that is most decisive, that has the largest influence on the development of the embryo. It's from day 4 that the quality of the genome from both sides, both the sperm and the egg, starts to show. And it's usually around that time, day 4, day 5, where many of the embryos either slow down or stop completely. So, by observing them all the way up till day 5, we actually follow this natural selection process. It's not a mistake to transfer after 3 days, but we learn much more about the embryos by transferring on day 5. And it's also actually this reflects in the boom of the time lapse techniques, which are various special cultivation systems that actually observe now the embryos not once a day, not once every 24 hours, but every, let's say, 10, 15 minutes, pretty much continuously, all the way up till either day 3 or day 5, to actually see and try and predict which embryos might be the most promising. So we do actually favor the transfer of 5 day embryos, even though it brings a certain risks regarding the number of embryos. Uh, this is also kind of an answer to the question, well, why do we need more eggs? Why not just 1 or 2? Because the process is quite complex, and at every step we may lose some of the strength in numbers. Not every follicle that is observed in the ovary actually carries a mature and healthy egg. Then not every egg that is actually connected with a sperm cell, usually using the ICSI method, will result in a healthy embryo on day 1, and not every embryo will develop into a 5-day blastocyst. So we want to start with actually sufficient number of eggs that would lead us to a promising number of healthy, strong embryos on day 5 for the transfer, and possibly for cryopreservation and possible other transfers. What plays a role? You all pretty much know this by now. The age of the egg donor may play a certain role, but the quality of sperm cells plays actually a huge role in this. There is actually the embryo quality, again, as the factor number 1. And of course, we want to ensure an easy retrieval process and a smooth, pain-free, flawless embryo transfer for the comfort both of the patient and the embryo and the physician, actually. Of course, there are some other factors on the side of the recipient, of the patient: uterine factors, anomalies, fibroids, polyps, endometrial receptivity, and possible miscarriage causes like the hematological or immunological issues. But usually these are examined before the cycle with egg donation is even started. If we want to translate that, the last 2 or 3 slides into numbers, this is what we usually see. The average age of the egg donors is usually, in the Czech Republic at least, around 24 years of age. At our clinic, the number of eggs obtained with the oocyte pickup is 11.5. Out of those, the rate of mature eggs is 87%. The fertilization is 75%. So we are seeing on average 7.5 embryos on day 1. And following the 5-day cultivation, we see 3.6 embryos in average per couple. So that's usually 3 to 4 embryos, sometimes 6 or 7, sometimes just 1 or 2. Okay. What does it mean in terms of pregnancy rates? Well, with the egg donation, the success rates are quite high. The first attempt, meaning the first cycle with those 3 to 4 embryos, so translated into 3 to 4 transfers, can really be uh, seen as around 70% or over 70%. And after 3 such cycles with a total of 9 transfers approximately, the cumulative success rates are up to 97%. That's why it is possible to offer these guarantees. Actually, it's just statistics and the biological processes behind those, as described in the previous slides. Of course, there are the advancements in technology, as we have already mentioned, um, more improved, more advanced methods of sperm selection, such as MAX, um, the magnetic activated cell sorting, fertilization methods, cultivation methods, the time-lapse techniques, and of course, a modern and much better cryopreservation methods in comparison with methods about 10 years or even 5 years ago. The current quick vitrification system actually ensures blastocyst survival over 99%. So these days it's very rare that the embryo wouldn't be okay after the whole cryopreservation process. It can be stored pretty much for an unlimited time, and its chances are after the thawing and the transfer are up to par with the fresh embryos. To understand the guarantees, okay, various guarantees are offered at various clinics for the egg donation treatment. We must understand the process and the biology behind it. Well, that's why we went through the previous slides, so hopefully we're a little closer to that. We need to look into the possible success and risk factors, well, and then try and understand the nuances between those. It can be quite mind-boggling, quite complex. Okay, what's more important? A sufficient number of eggs, mature eggs, embryos at the beginning, embryos on day 3, embryos on day 5, or the pregnancy guarantees? Well, we have pretty much just named the major categories. Let us look into that. Based on what we have said previously, it doesn't really mean much if we guarantee a certain number of eggs and just that number of eggs, because that doesn't guarantee promising embryo development, and it doesn't guarantee a strong number of embryos, okay, on day 3 or day 5 of that embryo cultivation. Even though, yes, it brings a certain value, I would probably personally focus more on guarantee of embryos, preferably on day 5 at the blastocyst stage. If we then try to take the next step from embryos to pregnancy, well, just as the number of eggs does not guarantee a number of embryos on day 5, the fact that the embryos are in perfect shape, are perfect morphologically, have been developing perfectly, and represent actually the best stage, like the top grade embryo on day 5, it doesn't guarantee that their implantation or the further development. So even stronger argument could be made for the guarantee of the pregnancy. These can vary quite drastically. Usually what the programs at various clinics offer is a free cycle after usually 3 failed attempts. So if 3 full cycles are repeated without a positive pregnancy test or a positive clinical pregnancy, better yet, then the 4th cycle is performed free of charge to give the couple another chance. Of course, again, between all of these cycles, always an analysis is performed to see what the possible causes might be for the lack of success for that RIF, the repeated implantation failure. Again, as far as the pregnancy goes, biochemical pregnancy on on week 5, sorry, and then here we need to realize that the transfer actually, since the pregnancy is actually calculated from the last menstruation, the transfer represents week 3 of the pregnancy, and the test about 2 weeks later represents weeks 5. Of course, yes, that's an important stepping stone, and it's always exciting and promising, but still, that time between week 5 and week 8, when the heart rate can be actually detected via ultrasound, or actually up to week 12, so the first trimester. This is a very sensitive time, and unfortunately, it is a time where a lot of things can go right and some things can go wrong, and this is a time when many of the pregnancies, be it following a spontaneous conception, or actually an IVF cycle, or unfortunately even an IVF cycle with egg donation, where the development of the embryo might stop and it might lead to an early miscarriage. Fortunately, the miscarriage rate in the cycles with egg donation is usually published as lower as the miscarriage rate in the IVF cycles with own eggs, and that's our experience as well. So the new trend and the novelty are the programs with live birth guarantees. These are still quite new, and I wouldn't want to go into any details. Sound interesting. I'll be curious myself to see how that works for the couples, if it brings more peace psychologically, if it makes sense financially. It's going to be very interesting to see. These are usually programs where the price at the beginning is substantially higher, but then there's a guarantee not of a number of eggs, number of embryos, or even positive tests, but a live pregnancy at least up till week 25, with that guarantee, or that the risk will be shared between the clinic and the patient, and then if such a pregnancy is not achieved in those 3 cycles, that most of the money, sometimes all of the finances, will be returned. It will be really interesting to see how these programs develop and what they bring. So why do we bother the patients with these guarantees? Why do we work on these? Well, we try to give them a peace of mind. Many of these couples, they have been through sometimes many previous cycles, sometimes cycles where the transfer wasn't even reached due to poor ovarian response or poor oocyte quality, and the egg donation is costly. By talking about these guarantees, we try to give the patients new hope, present actually the egg donation program for all the strength it brings, motivate them into going into that area with a completely different success rates, and representing, from our point of view, a new hope. There is one more slide and a couple of facts that I would like to mention at this point. It is quite often that during the early pregnancy, and that's not only following egg donation, it could be following a natural conception or an IVF cycle with own ovarian stimulation, but in the egg donation cycles as well, that a slight spotting or even bleeding may occur. Don't automatically get stressed out. This doesn't automatically need to signal a miscarriage. Usually it represents a nesting bleeding following the implantation of the embryo, and in such a situation, bed rest and sticking to the medication plan are recommended. These are the best things to do, usually, honestly, the only things to do, because at this point there's hardly anything else we can do to increase the chances of the embryo to fight on. Aside from staying in contact with your clinic and your doctor, there are some things that you can do to prevent, but these are quite simple, quite logical. Taking the medications to keep the uterine lining stable and happy, a well-balanced diet, moderate exercise, don't go breaking any personal or Olympic records, then avoiding high levels of stress if at all possible, because the IVF cycle in itself actually brings quite a level of stress, and avoiding abuse of harmful substances like alcohol and drugs. And well, after all of that, it's still rather complicated and complex. And like I usually or sometimes say after the transfer to my patients, welcome to the world of parenting, where all you can do is actually give the children all the advice and all the equipment and the food and everything they might need in the morning. But still, after that, you have to send them out there in the world to school, kindergarten, university, whatever. And then you pray hard for the rest of the day to see what they come back with later that day or at night. It's similar here. We do our best to actually provide you with a great embryo, an easy transfer, and the best possible conditions. And of course, the same goes for you. You do your best to actually prepare the perfect milieu for the embryo to nest in, but then it's up to the embryo itself, and we actually have to wait it out those 2 weeks and hope for the best. So that's what I'm going to do right now. I'm going to wish you all the best and the right amount of luck. And I thank you for your attention, and I'm ready to answer your questions. Thank you very much, and have a great evening and good luck.
And thank you, Dr. Thomas. It was a pleasure to listen to your presentation, which was very informative indeed. And we have already some questions on
Okay.
the list. So we will take it one by one, and we will now go with the first one. I would like to know, what do you think about giving a desapeptyl depot injection in the cycle before transfer, if it's possible that this injection is responsible for implantation failure?
Okay. We have stopped to use it a long time ago. Actually, even 10 years ago, we preferred rather like small doses of decapeptyl administered daily over that one depot injection. Even though the depot injection represented a strong alternative, but we have actually completely skipped that step in the past 5 years or so, because it didn't seem to have any positive effect on the outcome. It didn't really help us much in planning the cycle, and it was not popular with the patients because it was rather expensive. So we have tried all the various protocols with a single decapeptyl shot, with the small dose shots, even with the antagonist, but since approximately 5 years ago, we have started to use the protocol where the estrogens are applied at the dose of 6 milligrams daily from day 2 of the cycle. And this dose in itself actually has a downregulatory effect on the ovaries. So we don't really need to worry about a dominant follicle growing and eventually disturbing the preparation and the cycle. I wouldn't go as far as to say that the injection might be responsible for the failure. I don't know if there's data for that, but it's expensive, and we don't use that anymore. There are other alternatives.
And thank you
Mhm.
for giving us the whole picture and answering this question. We have the next one. I have my first IVF cycle with 34. Is it possible that my eggs were poor quality because of endometriosis at this age?
It's a very good question, and it's really hard to say to what extent the endometriosis influences Well, not only the ovarian reserve, the quantity of the eggs, but the quality of the eggs and eventually the receptivity of the endometrium. There are some studies and there is some data that suggests that yes, the endometriosis works, actually has a derogatory effect on many levels. And it might be a part of that equation, but I don't think that it's just simply endometriosis, and I don't think that you should give up in this case after the first IVF cycles. Maybe there can be some adjustments made in the protocol. Maybe with a higher dose, a higher number of eggs may be used. So I would try again. On the other hand, it's really hard to exclude that. So it may play a role, but I won't be able to express that in percentages.
Perfect. Thank you for the great question and great answer as well. And we will now take a look at the next question, which will be this one. Do you select donor eggs for their morphology? Do you rate them? How is your score?
Okay. Yes, as you may know, morphology, okay, so the build of the cell and then eventually of the embryo, that's pretty much the main factor in evaluating them. Sorry, long day. um, I have to admit that I'm not quite familiar in detail with the scores that the embryologists use. They do use scores. I could comment on the scores for the embryos during the development, but the eggs themselves, I know that they do have the scores, but I couldn't give you an example or averages. But the answer to that first crucial question is a sound yes. Of course, it's their morphology, but there's many things that play a role. Are they ripe? So is the polar body, well showing and expressed? Then do they have fragmentations, etc., etc., etc.? And usually these are described in great detail in the embryological protocol. And only the ripe eggs of being deemed of perfect quality are used for the fertilization in these cycles.
And thank you for your answer to this question and for the question, of course, as well. We will now take the question, which is still about matching, but in a little different sense.
Mm-hmm.
How does your team match donor to
Okay.
recipient? Would you look at photos of the recipient's body type and facial structure? Do you consider factors other than hair and eye
Oh.
color? Dimples and a nice smile are important features.
Oh, that's such a sweet question. It's my favorite one. Okay. Since it's an anonymous process, there are actually some very strict rules and regular checks from the Ministry of Health of the Czech Republic. And there's only two people at the whole clinic who have access to the database and to that matching process. And I'm not even one of those two. What I know that the head coordinator who works on this uses are yes indeed the photos of the recipients, the body type and the facial structure. Definitely, we always actually motivate the patients to send some photos, some typical photos of the couple, not only the patient actually, and that is taken into account. Unfortunately, we are not able to show the photos of the donor to the couple to present those because that has been discussed at length with the lawyers, and they said that that might represent intrusion and actually breaking that anonymity law. Other factors other than hair and eye color, dimples and a nice smile. Oh, that's of course, yes, these are very important. But honestly, I don't think that the genome, okay, and the genetic predispositions will have actually the crucial influence on the looks and not only the visage, but the aura that the child is going to carry. And I think that the upbringing and the influence of the mother and the family, both during the in utero phase in the uterus and then after birth, has actually a much stronger influence. But the dimples, we'll have to look into that more. That is quite true. Beautiful question. Thank you.
And thank you for the beautiful question and for the great answer. And yes, we will take the next one. Thank you for your informative webinar. Thank you for this as well. In relation to progesterone, you stated this was used to help the lining become receptive.
Uh-huh.
Do you have tests to ensure activity, or is it just assumed the medication will work? Thank you.
Mm-hmm. Thank you for the question. Yes, we basically work with tons and tons of data that was made available previously. That actually is built on the physiology of the normal, typical run of the menstrual cycle, where that implantation window, the phase where the endometrium is perfectly ready, usually comes 5 to 6 days after ovulation. Actually, it has been tested many times that usually it's 120 hours of progesterone before the endometrium is just right. Of course, there are still arguments of how wide that implantation window is. Is it 1 day, 2 days before the endometrium, so to speak, grows old or overripe? Um, there are some tests, but they are quite elaborate and quite expensive. You may have heard about the ERA test, ERA, endometrial receptivity assay test that's performed in Valencia in Spain. And in that case, the endometrium is actually prepared just like for the transfer, including the progesterone application. And then instead of the transfer, a biopsy is performed. And in Valencia, on that probe from that endometrium, they actually run analysis to see detect gene activation, and as a result, they show whether the lining was receptive or whether it was not ready yet, and next time it needs a couple more hours, 6, 12 more hours of progesterone, sometimes a little less. This is still fairly new, and it's not an easy test to make. So I have to admit, yes, we actually built on the previous experience and on the data available and accepted all around the world. 120 hours of progesterone prior to the transfer. Of course, there is one actually experience that is really, really important. If the patient did have a positive HCG test in one of her previous cycles, then we always look at that cycle and we look at the length of the progesterone application prior to that transfer, because this might serve us just as well as the ERA test, showing when and whether the endometrium was receptive. Thank you.
And thank you for your answer to this question. And yes, we have the next one coming up. So it's quite interesting one. And if you have any comment and opinion, we will be glad. A French gynecologist advised my friend against IVF donation in Ukraine because the possible bad effects
Mm.
disaster on the donor's health and because she can have a sick baby. What do you think about that?
Oh, that's a very interesting question, and that's one that, quite honestly and quite briefly or directly, I don't have an exact answer to. I'm sorry. I don't want to hurt my colleagues in Ukraine suggesting anything directly. Of course, there might be effects, but I'm afraid it's not only over Ukraine. It might be over the whole of Europe. Um, from that unfortunate time. But I don't think that anyone will be able to really express that in studies and show whether that is a part of, say, for instance, the Porter spermiograms that we see in the past couple of years, or if it's, or to what extension that is a significant part of that. And honestly, I cannot answer that question, but. Just as everybody else, yes, I am concerned for the health of us all and our kids. So hopefully, bad experiences like that will, be avoided in the future. But I don't know. I cannot give you any numbers. Sorry.
Yes, of course, understood. And thank you for your opinion anyway, and great question and answer as well. The next question will be this one. What immunological treatment do you practice?
This will be really simple. The one that the immunologist suggests. Okay. I always put a lot of emphasis on this when there's repeated implantation failure, okay, or miscarriages. No matter how hard we try to educate ourselves, we can simply not, live up to the potential of a truly experienced reproductive immunologist, okay, or a specialist in reproductive immunology. So yes, we are able to run some tests or even panels of tests and interpret them, but usually, whenever there's suggestion of trouble, we advise the patient actually to the immunologist who performs maybe an additional testing and then sends the patient back with a specific recommendation, starting usually with application of corticoids in the cycle, all the way up to application of human immunoglobulins or intralipid infusions. All of these may be a part of that treatment. So yeah, we practice most of the usual treatment, but we try to involve the immunologist if at all possible.
And thank you again. As the time is flying, we will not waste time and go straight to the
Yes,
next.
please.
Up to what age are you able to offer a guarantee program? I would like to proceed with own X. I'm 43.
Okay. Uh, the okay, the live pregnancy or the live birth program actually is just being formed, shaped, and started. And I believe that the age level there will be 45. So you should be okay. With 43, there shouldn't be any limitations. You should be perfectly all right.
And thank you for the sharp answer to the
Of course, I'm sorry, I still
no
have to
problem.
add, if it says here that I would like to proceed with own eggs at 43, that's a different question. And actually, I was answering something else, okay? Because the guarantee program, of course, is in this case specifically designed for patients with egg donation. With in a cycle with your own stimulation, we can try and we can give it our best, but there's no guarantees whatsoever because the success rates in this age group between 40 and 45, and especially 43 to 45, are very, very, very low, and the outlook very dire. I'm very sorry to say that, but the success rates are usually published around 1 to 3%. So there's absolutely no guarantee that we can give for the stimulation with own eggs. Sorry, this is the true answer to the question.
And thank you for this additional comment and the answer as well to the question. Next one on the list is this one. What do you think about scratching of endometrium in the cycle before transfer? Is it possible that the natural killer cells are higher because of scratching?
Is it possible? Yes. Is it guaranteed? I don't think it is. The initial study on a relatively small group of patients was promising, but after that, there were numerous studies that failed to confirm that effect. So I don't think it hurts. I don't think it lowers your chances, but we don't believe it's that effective that we would incorporate it in our protocols. If the patient wants to have that, or has it recommended perhaps by her gynecologist, we're not against it, but we do not proactively recommend that.
Thank you again. we have the next question to publish, and this will be this one. What is the maximum stimulation, maximum number of oocytes obtained, which you recommend?
Interesting question. Uh, of course, when we think about the dosage, okay, for the stimulation, we take many things into account. The estimated ovarian reserve based on AMH levels, anti-Mullerian hormone, and AFC numbers, anther follicle count, the number of follicles, based on the age of the patient, based on previous experience, etc., etc. Um, the maximum stimulation. There are many studies that show that the maximum dose, the maximum initial dose of FSH, follicle stimulating hormone, applied via injection during the stimulation, that makes sense is 300 units per day. And that if you go any higher, you won't really increase the chances of the patient for a healthy pregnancy. You might increase the number of eggs obtained. You might increase the number of well-dividing embryos, but ultimately the take-home baby rates are the same. At the same token, I have to admit that sometimes with a specific patient, when with 300 units per day, we did not achieve the goal and the number of follicles and eggs was low. Sometimes we do start higher, but never over 400 units per day. I don't think it makes sense to start with 450, 500 or higher. I don't think it's going to bring anything else. Maximum number of eggs, that is quite individual. There are women, regardless of age, that will have only 2 or 3 follicles and eggs in every cycle. There are some which will have 23 and 24. Usually 10 to 15 is given as an optimal number, although now at the age of cryopreservation, and we have mentioned that in the talk, where the embryos, if there's a risk of hyperstimulation, can be effectively and safely cryopreserved. The ovaries are left to rest, and only when it's safe, then the transfer comes. And then, of course, this might result in a cryopreservation of 7, 9, 11 embryos, thus actually preventing that patient from any future stimulations, because she will have enough embryos for all the pregnancies that she might wish for. So this isn't as strictly uh, divided now, but usually 10 to 15 is sufficient and a reasonable number.
And thank you for your answer to this question. We have still questions which are coming up, and of course we have time running, so we
Running a little
will,
late, isn't
yeah,
it?
and we will have time for just a few, maybe 2 of those
Okay.
questions. But if any question will stay without the answer, be sure that we will forward everything to UNICA Clinic tomorrow. And of course, if the question will stay without the answer, we will try to handle the situation, and you can be sure that we will,
We'll
yeah.
do our best to respond in a timely manner. It might not be tomorrow, hopefully before the end of the week, so that you don't have to wait for your answers too long.
Yes, indeed. Thank you. And yes, as I said, we will take then the next question, which is this one. How many times is donor donating eggs in her life usually?
Good question. Not many of them want to do this repeatedly because it's not an easy procedure, as many of you know. We do have a certain limit, and that is it's usually up to 5, no more than that. This is also for concern for the donor herself, because we cannot be sure, what long-term effect it might have on her ovaries. We're also distinguishing between a donor that has 2 children and doesn't plan on any further pregnancies, and the donor that actually didn't have any children yet, but usually after 5 stimulations we don't recommend any further ones for her own sake.
Yes, and
But these are rather rare. Donors that want to donate repeatedly. I'm sorry, excuse me. Next question, please.
no problem, no problem at all. Yes, of course. Next question. What do you think of PGS? Do you do that at your clinic? Does it have to be done while the embryo is frozen?
Hmm. Okay, good question. It's a very broad issue, and it's a very interesting topic. So that might as well be the last question that we will respond to today. Uh, it's shaping up to be a very interesting tool. The recommendations may quite vary at different clinics, different countries, different groups of patients, with ONEX as a tool to actually select the embryos for transfer. Yes, and we do recommend that. Some say over 33, some say over 36. There's still some conflicting data, so this would be a long discussion. But basically, for the stimulation with ONEX, yes. But in the cycle with egg donation, generally we don't recommend it. It's costly. You would have to freeze the embryos. So yes, we do that at our clinic if the couple wishes so, or if it's necessary. Um, for instance, in a situation where it's donated eggs because of an age factor in the woman and the gentleman has a specific genetic problem, then it of course wouldn't be the PGS, the screening, or as it's now called, the PGTA, the pre-implantation genetic testing for aneuploidies. It would be for a specific diagnosis, the PGTM, but yes, we do actually have that available. Now, for the last question, uh, it's not done while the embryo is frozen, but the embryos have to be frozen after the biopsy is performed. So on day 5, in the well-developed embryos, the biopsy is performed, the cells are actually collected, and then the embryos have to be cryopreserved and wait at the cryobank for the outcome of the test, which sometimes takes a month, sometimes 2, or even a little bit longer. Only when we get the result from the genetic lab and when we know which embryos from the cryopreserved ones are the healthy ones, those are then prepared for the transfer.
Yes, and thank you for the final question, which was clever. It was 2 questions in one, so
Actually, 3 almost.
yes. And, as I mentioned before, if any questions stayed without the answer, you may be sure that everything will be forwarded to the clinic.
Thank you
That,
very much.
yeah. I have actually I have more thank yous for you. Thank you for your answer and appreciate it to the question about age and guarantees. And of course, thank you for the presentation
Thank you,
and
guys.
for being here with us. And of course, I can go further. Thank you and more thank yous. And
It's very
thank you
kind.
everybody for being with us today. Dr. Thomas, if you'd like to add anything, any final comment?
I would only like to thank you one more time for your participation, for your wow, for your attention and for your great questions. I wish you all the best. Well, starting with a good night tonight, but the best of luck with your future tries. And well, maybe we'll see some of you in person. I'll be looking forward to that. But no matter where the future leads you, best of luck, and it's been a pleasure. Good night. Bye. Thanks.
And thank you for very informative presentation and for all your wishes and keeping fingers crossed for us here. Of course, the rewatch will be available on our website tomorrow. And of course, you can follow us on YouTube or on Facebook or Instagram, where you will be always up to date. Thank you, Dr. Thomas and UNICA Clinic one more time. Good night, good day, wherever you are. And yeah, bye-bye.
Thank you. Good night.